Hi everyone, and welcome to episode 25 of The Only Way is Ethics. We've been away for a while and I'm pleased to say that we're back, and very pleased to welcome our guests for today. So we have Clive Flashman, we have Shane Tickell, and we have Hassan Choudhury with us here. Thank you for joining us, and as you know, you can find us on Spotify and YouTube. So we're going to crack on. So today's episode is very much focused on the NHS 10-year plan. We know it's just been published. Already there's people out there making comments and with their own opinions. But today, we've got the opportunity. We've got 3 people in the room, or 4 people in the room that pretty much know their stuff within the digital health community and have been around for a while. So excited to start proceedings off. We're going to get everyone to introduce themselves in relation to the first topic. So we'll crack straight on, and we're talking about AI in the NHS. So part of the 10-year plan, the NHS to become the most AI-enabled health system in the world. Big ask. And the promise of AI scribes, big in the news at the moment, predictive triage tools, clinical automation, lots to think about. And how are we going to deploy this to be meaningful and not be overwhelming in relation to what we're doing? We've got a general public that, again, are they AI enabled, or are they prepared to take on AI? I think at the moment probably not. That's my opinion. But again, Hassan, can we start with you? Is that okay?
On the idea of an intelligence revolution, I don't really know what that means, and I'm really concerned when these phrases come out, AI enabled. And it starts to make me think, hold on, can you just speak to me in really simple language? Because this is the nation's health service, and it's going to speak to all of us. And in some ways, the plan deviates into the kind of tech bro speak that I think is a bit of a problem. Truthfully, this isn't magic. AI, machine learning, deep learning, computer vision have been around for a very long time. It's definitely as simple as get the right data in, do the right things to the data with the right governance structure, and make sure you buy it in and not land it on people to use, right? Yeah. That's what we need to be AI enabled. Mm-hmm. And that was true before the publication of the plan. Mm-hmm. So I'm really looking at the plan to see what does it really say. And forgive me, this is my hot take on the plan. I think that it's not a plan. I think that this is just lots of initiatives thrown together, but infused with the right language, so it feels like we have a plan. And it's an updating of what we've done before. It effectively converges everything that we have been talking about for a very long time, and tries to put that into maybe a framework that's easy for us to talk about, but it's not a plan. We're waiting for what does this really mean. And if you've got, like I do, a few too many grey hairs, right? If you've been around the block, you've seen it before, you've seen neighborhoods before, you've seen prevention before. AI intelligence revolution, please. No, I don't buy it.
Okay. Before I move on and we take sort of like comments from everyone else, give us a bit about yourself, Hassan, and sort of, your background and how you got to where you are now.
You're very kind. My bio makes people laugh because at the end of it, no one knows what I do. So I'll start with this. I had a long career in informatics in the NHS, which is a nice way of saying, what's the art of the possible? So we separated performance from informatics. So I was in the informatics side. And then 2 friends of mine said, why don't we start our own business? This is when Lansley was coming along. And we ended up in a space called real world evidence, which is how do you know what's actually routinely happening in healthcare? And I was measuring, like a health economist might, I was measuring what it is that was happening so that generally pharmaceutical, life sciences and others would say to me, how do we prove the value of the intervention? And I did that until we sold the company back in 2019. and then I joined UK government. I was named as their expert for global digital health for international trade across 96 countries for 4 years. And so now I'm a bit portfolio. I've just set up the commercial functions for Great Ormond Street, which is the 4th best children's hospital in the world. I'm commercial director for cancer at the Health Data Research UK hub called DataCan, expert in residence at King's, and a few other things.
So you've got your fingers in many pies in relation to that. And interesting you saying about sort of, talking about AI and this sort of like, this revolution. Is it a revolution? A lot of the things that we're talking about within the plan, is it a plan? For me, when I started reading through it, it looked like a bit of a manifesto in relation to sort of getting the information out there. And there's lots of terms in here, and there's lots of things that are familiar to us, and we've heard before.
Can I just say that I think it's a shopping list for many different meals and many different recipes. And therefore, there's conversation about what we do with dentistry, and there's conversation about what we do with community pharmacy, and there's discussion about what we do with ambient voice technology, and there's conversation about emergency care. These are all different recipes. They all have different ingredients. This is a wish list, a shopping list of what we do in all of those. It doesn't really tell me there's a banquet. It doesn't tell me what the purpose of the banquet is. And it doesn't tell me what the outcome is going to be. I love the fact that these things are there.
Oh, absolutely.
I just don't think it's a plan.
Yeah. So with that in mind, and we've got this shopping list, so sort of, but there seems to be this overarching thing that potentially AI is going to solve all our problems. So Shane, sort of coming on to you in relation to your role, and I know you'll take the opportunity to introduce yourself to everybody, but sort of like very heavy on sort of like on data and data services as well. You've had a lot of experience in relation to that, and we all know that AI is sort of like totally 100% reliant on that data, and how we safeguarding that in relation to the patient, and sort of making sure that that they're getting what they want.
Well, if I may, I'm just going to quickly start as Hassan did when he introduced himself. If I have a specialism, it's real-time healthcare data. That's my focus for the last 29 years. In modern day terms, that's about 3 centuries. But in all seriousness, my roles have been related to very specialist electronic patient records, right the way through to very generalist, wide platforms with millions of people's data on it, bringing together data. So from running what we'd call standard acute community electronic patient records, right the way through to running mission critical large population data real time from primary care, acute, community, mental health, ambulance, you name it. And that's my passion. I do have several roles built around that today. But your point about fundamentally safety. Now, here we are in the patient safety learning offices, which is fantastic that they've made the facilities available to us, and some wonderful phrases on the wall. Fundamentally, to do anything with any data, forget AI, we need the data to be clean, accurate, and as up to speed as possible. And that's why real time for me is absolutely critical. And what you can do with that real time data, and it's not just data, it is multimedia. We need to bring that in because imagery, sensitivities, measurements, all kinds of things will come into, I think, the care of citizens over time. So we're really still at somewhat of the foothills of this. So patient safety and clinician safety and people provided services, mission critical means 24/7 on full time, because as humans, we're never switching off. We don't choose what time we get ill. We can't choose, it's 5 o'clock Friday, I'll wait till Monday morning. So mission critical is absolutely the thing. I'm going to quickly try and address 2 things. One is the AI piece and then the plan. So AI, I don't think we start with we're going to be the most AI-ready healthcare system in the world. What we need to do is use tools to enable the safest, fastest, best healthcare delivery and prediction and prevention as possible. AI will play a part. The thing about the plan is, and the work and the philosophy as we go now is, technology, data, it is going to enable so much. It's going to enable parts. If you look at the plan, and can I just caveat, the plan's about 36 hours old in the public domain. Okay,
absolutely.
so like last night we were at an event, people are having opinions, people haven't read the plan yet. And in all seriousness, the plan that you've seen, and I'd like to address a comment that Hassan has rightly said, the document that's been released isn't a plan. And the document is 135 pages of aspirations and aims. It's also got 30 pages of links to relevant materials that were used in the preparation of this work. So, but I have to say, it's really difficult. What do you call it? Is it, you could have had a debate about what to call it. The truth of the matter is, as of 9 a.m. yesterday, those of us who actually worked on the plan, so there were 270,000 contributions, but there were about 170 of us that worked on the different groups. And I was very privileged to work on Group 4, which is the Digital Data Technology Group. There were 17 of us invited, and it was chaired by Dr. Tim Ferris and Ming Tang. Ming Tang being our Chief Digital Information Officer for the whole of the NHS. And it was by personal invitation for them, and they handpicked the group. And we were so blessed to have CIOs, CEOs, chairs, representatives of social care, international CEOs, as well as the Tony Blair Institute Health Foundation. And I had the privilege of being the only person to represent industry in that room. And I hope genuinely to have done best to represent what we wanted to do. But we recognized that these were a set of aspirations. And we were in Group 4. As I've read the document so far, I think it is the most wide-reaching. So it reaches into the social determinants of health. And I genuinely and passionately, although my specialism is real-time healthcare data, it's because I want to serve society. I want people to be well for longer, to live a better life with their choices. And the social determinants of health, or our social construct, very much dictates so much of our disease and our state. So if you look at the plan as it is, what it's done is it's tried to take into account from the social determinants of health to what we need as a workforce, to what we will use technology for to enable better care, financially better. They've looked at how we spend money as a country, as a government, to go from this horrible fiscal, which means annual amount of money, you don't know how much you're getting sometimes until the year has started, through to longer term planning. So everyone's allowed an opinion. And I would say this as well. It's a 10-year aspiration to enable the next 20 to 30 years. That's a generation. And there is an element of understanding that centrally we can do so much, but locally is where it has to be owned, delivered, and that people are really going to make the difference to own this for a longer term. But this is the bit I'd say here. We fully recognize it needs to be iterated. This is just the start. The document is going to be out of date within a week because we'll have new ideas. In 3 to 4 years, one would hope, things will be invented we can't even conceive of today. So I personally am humbled and privileged to have been involved and to see the output so far. The work group, I believe, our materials are going to be issued over the next few weeks. So it could have been framed better and counseled and launched better, perhaps. But this is a start. And I think the aim is that we as a country, as a nation, whatever your role, we have the opportunity, we have a license from government to support, to spend money, to make changes. And with a fabulous NHS board, the leader of whom, Sir Jim Mackey, says, look, if the rules aren't working, do what you need to do and we'll fix, don't just break the rules, but we'll do what we need to do around it. Yeah. And that comes to me, and let me hand over now because you've been ever so kind to give me this start. But AI isn't an aim. AI is one tool of many. And I'd love to come back to this a little bit more because algorithms, efficiencies, that's what we're using for. We don't aim to have an AI-enabled health system. We aim to have the best healthcare system in the world.
No, absolutely, and it's enablers as well. And thank you for that, Shane. Clive, so in relation to this, and Shane's made that point as well. It's about sort of like localizing, isn't it? We've been very much a health service that's very been sort of like secondary care centric in relation to what we've been doing. And there's been talk for many years about doing this, but I think Shane, you're right in relation to whether it's this shopping list, this sort of like, what do we call it? I say, I don't know, framework, etc., and being enabled for to be localized, but are we just moving the problem somewhere else? Can it be, do we have the infrastructure? Do we have the capacity? Thinking from a safety perspective as well in relation to that. People in their homes with technologies, from my perspective, because I'm going to be very, very selfish in my sort of risk management side of it, has a lot more issues for me than keeping it in the sort of like the hands of the clinicians.
Okay, so I'll start with the intro.
Yeah.
So I started off as a finance guy. I then became an informatician, and then became a healthcare strategist. And I do strategy of all different types now, different colours. But I'm also what you would call potentially a business architect. So I look at companies and I work out how they can refine, streamline their operations, generally working with the NHS or other companies to do what they do as effectively and efficiently as possible. Okay? And I've worked in a number of organisations around that. I'm also Chief Digital Officer in several organisations, one of which is this, Patient Safety Learning. And I'll wear that hat particularly today, I think, on this podcast, talking about some of the patient safety implications of the plan and the things that we're talking about. I mean, is it a plan? I don't know. Yeah, it seems more like a set of aspirational targets and tools to me. I mean, if that's the distilled shortlist, God knows what the long list was like, because there is a lot in there. And I think it's great, but actually there's a humongous gap, and that is social care. So the fact that there is nothing about social care in there, for me, makes it almost unworkable. Because, and I was talking to a doctor about it this morning, anybody who knows healthcare knows it's all about the flow, okay? And if you've got people in beds who shouldn't be in those beds, that blocks everything else up, all the way from getting people into A&E from happening as it's meant to happen. And we're not addressing that. The KC report's due to come out in 28. It's the year before the election. No government in its right mind is going to have that coming out the year before the election. So it'll be kicked into the long grass. So there won't be any social care policy or plan this government. And you cannot look to fix, because Labour say it's broken, you cannot look to fix healthcare unless in parallel you fix social care. Darzi didn't do his data compendium on it either. So there was a vision from the beginning that social care was going to be left out. And for me, that was the wrong move. Now, if you're doing neighbourhood care, a massive part of that is social care.
Absolutely.
Okay? Caring for people in their own home, whether that's dom care, home-based nursing care, whatever it is. There's a massive amount of social care. So if you're not looking at that aspect of it, when you're looking at community-based care and neighbourhood-based care, that doesn't work. It doesn't work for me. And I think one of the issues from a patient safety perspective is that in hospital, we know how things work from a clinical governance and a patient safety perspective. We have tried and tested systems for incident reporting. Yeah. We know what's meant to happen if there are issues. We have PSERF now around incident investigations. All that is reasonably mature in a hospital setting. It's never been that in the community. So when I designed and launched the patient safety system in 2003, and we tried to get GPs to be part of that reporting system, I'm not going to say which organisation I spoke to, but you'll probably be able to guess, on behalf of GPs, they told us that GPs would only report if we paid them each £50 a time to report. Okay? Sort of reflects on the origin story of the NHS in the first place and what was the famous quote about GPs then. So there's an issue with having these sorts of systems and processes embedded in primary care and community care and even social care. Okay, we've not done it before. And if those patient safety guardrails are not well established in those settings, if you look to transition care out for those, you're putting everybody at more risk because you haven't established the safeguards or the guardrails to enable people to do that. So what I'd like to see, and I'm going to do a little plug here, unpaid, is a sort of thing that Yorkshire and Humber HIN do.
Yeah.
Okay, so they've got a very successful accelerator called Propel.
Yep.
But in parallel, they have something called the Digital Ambassador Program.
They do.
And what that does is it upskills people, and it's not just in healthcare anymore. And I lecture on that, so I've seen it firsthand. It's started off in GP practices. It's also NHS trusts, so large hospitals, but it's also councils now as well. So what it does is it equips those people to understand the digital agenda, to receive digital innovation, and to understand how to maximize the successful ways of implementing that, and then to actually do that, okay? And to understand the risks inherent of doing that. If we are going to bring those types of innovation and more, the AI ones and everything else, if we're going to bring that into these other care settings, we've got to digitally upskill those people. And it's no point having the innovation landscape described from the point of view of the SME or the NHS Trust. That landscape is much broader. It includes all of the staff in all of the settings, including the third sector, and also the patients or citizens too.
Yeah. Because
the healthcare literacy in this country is appalling. The general literacy in this country is awful. The reading age is 9 years old. And if you're talking to people about healthcare information, particularly with numbers in, you need to make sure that they understand how that will work. And then there's been this sort of focus now in the plan to some extent on patient empowerment. Empower to do what? Generally, empowerment means, when it's talked about in this regard, we will share accountability for your care with you. You will have to take responsibility for your care. Well, how are they going to do that? Who's educating them to do that? If it's patient-initiated follow-up, PIFU, to do that, you need to understand your pathway. Who's telling them what their pathway of care is? Nobody. Is that going to be the NHS app has a little visual diagram of their pathway?
So interesting you saying that, and that leads us, doesn't it, down to that path of, you've mentioned the NHS app, and we're talking about the doctor in your pocket in relation to that as well. And is it all about the NHS app, and you're saying about PIFU, etc.? And where are we leading in relation to sort of, the expectation that sort of accountability and decision making, and we're now passing a lot of that over to the patient? I see it personally in my sort of personal experience in healthcare and the decision making and etc. and stuff like that. My personal experience is, though, I'm a clinician. Therefore, I'm at an advantage because I have a knowledge base in relation to that, and I might know the questions that need to be asked to get the right answers. But the bigger percentage of our population don't know what questions to ask. And where are we going to be given support in the NHS app in relation to that? Is the NHS app, is that the advocate for the patient then? Because lots of them don't have one.
I'll be brief on this, on economics. I think there's a mismatch of supply and demand. The amount of care that we can provide and the amount of care that's being demanded, patient contacts. And that's why there's such a focus worldwide on putting the responsibility and the burden back onto individuals and families to look after themselves, because we don't want them to be constantly coming in and drawing those contacts. It's a bit like a blank check. If you don't do anything to stem that tide, your urgent and emergency care will get completely full up, ambulances will get full up, GPs will get full up. So that's part of the motivation to do so. And therefore, because it isn't quite as sincere as how do I help a person self-care, and truly empower them. It doesn't come from that. That's almost like the fourth question, because the first question is an economic and demand management question. That's why it's become an afterthought. That's why design hasn't been at the center. User-led design and user-centered design and co-production hasn't been at the center of what we've done here. The app, the NHS app, is a huge opportunity. But I look at it and I wonder what could be, what it might be. And I want it to be UCD-led. I want it to be with the best practitioners in the game. I want it to be co-created and co-produced with people. We shouldn't just think of them as patients or service users. And if we can make that feel like it's theirs rather than imposing it, which is the problem with most things in healthcare, we're paternalistic. You will go and sit there, you will come back there, you will do this. And unfortunately, that's how all of our pathways have been built. The app is a way to move away from that, to sublimate away from that. And unfortunately, the app is now just an extension of the old way of thinking. We have to now think differently. And that's, forgive me, when I talk about this not being a plan, the 10-year plan, I don't mean I disagree with the things within it.
No.
I just can't see the overarching thread. The overarching thread is not neighborhood. The overarching thread is not prevention. Those are not the overarching thread. The thread could be a learning health system where we learn from what we do because we capture data, turn it into knowledge and feed it back in. Right?
Hassan, I don't know. I think the thread might be do more with less in more affordable places.
If that's left shift, for example, if that's a thread, then starting with we want to embrace left shift, now see the things that we're going to do leading to left shift. I can then argue with you about the overall point of the plan and the elements within it. That's why, for me, the NHS app feels a bit lost. What is it? Is it the continuation of the old way of thinking, or is it the vanguard of a new way of thinking?
And I'm going to really jump in on this. The NHS app is a door. It's a door. It's a communication. I think it is what we need to design it. If you look in the plan, what it says at the moment is, I as a patient will be able to X, Y, Z. My expectations are. And I think we need to just have a look for a second. If we think of ourselves as citizens, and I am thrilled to see that, we'll come on to genomics and DNA and the prediction and prevention. So anybody who's sat in an A&E department or an ED department, as we've been called for 10 years, recently, and I've sat in 2 in this year during the night, I've seen all kinds of people come through, and the expectation, so you see people coming through, and you hear it all the time from our professional colleagues, they are attending inappropriately because invariably either they can't navigate the system because it is so fragmented. The GP now is closed at about 4:00 in the afternoon, and then it goes to out of hours and all kinds of things. How do you actually get into it? And there are other people who just turn up because, they just don't know where to go. And they don't have the social, maybe when we were younger lads, we had families and people who would sort of, give you a bit of advice about something. You didn't have to run to A&E. What you could do is you could try a thing at home, you could go to the chemist, you could maybe then you go to your local GP. So the system is overwhelmed. And if I can just put a few numbers on the size of the system, clearly we've got about 70 million people in the UK today, so not just NHS England. We've got 1.2 million-ish roles, nearly 1.3 million roles in the NHS and a 10% shortage. That 10% isn't going anywhere. We have about 1.8 million people working in social care. And then as regards patients, carers, there are allegedly 4 million people in the system. Then you add in the patient. Yeah. So, there's an awful lot of people actually working within this with an awful lot of needs. But if we look at from from conception, from life, right the way through, we need a front door, which I think is what the NHS app is meant to be. And then it'll be underpinned by a single patient record so that all of the information from you. But you made some really valid points about social care. And if I can just say, we really did try and raise this an awful lot, but it's an NHS plan. But the NHS is responsible for social care. Now, in law, it doesn't quite work that way. But the clue is in the department name, health and social care. So what I would say, Dean, is they have to start somewhere. This is an iteration. You cannot ignore the social determinants of health. And 4 million people are being cared for.
No, absolutely. But can I just come in there and just say, and this is something that's really, really sort of got me, look, and I'm going to hold my hands up. So the social care side of it has always been there. But I'm an acute nurse, from secondary care. That's what I've known. Then you're thrown into this sort of like, not thrown into, but I came into the sort of digital health arena, and you start working for a big EPR supplier. And then your focus at that time is secondary care in relation to that. And then all of a sudden, when you sort of, your role changes and you're in this regulatory space, and then, I found this sort of, they're almost like the distant cousin that no one ever sort of like sees or hears from, is social care. And when I started sort of realising, it was like, these guys, and somewhat primary care as well, but not so much because, GPs, etc., and they're sort of like, got a responsibility and they know a bit more. Social care guys just knew and still know
it's
nothing.
Hard, it's tricky, it's
know
poor.
Nothing about. But why have we? Where did we get to this position? Why have we got to this position in relation to as an NHS that these guys have just been forgotten about? I don't have those answers because it's something that's sort of like
the wearables agenda in the plan, and who do you need to capture the data from? Very often elderly people who can't use those. Who's going to be best placed to help them apart from their families? It may well be the social carers who go in and help them.
Yeah.
So there is an inevitable link there between the NHS agenda of capturing information in situ, wherever they happen to be, and using that with AI to predict escalation or crisis, but the patients who at home can't use these tools necessarily easily and need support to do that, which inevitably people best placed in the home, apart from family, are social care. But they're not tied into this. There's no joining up. And so there are various aspects of this plan where for it to work, there has to be that bridge between both of those subsectors.
No, you're absolutely right.
Dean, I used to work, and I wasn't qualified as a social worker, so I'm not allowed to call myself that. But I did the job for 3 years for the elderly in Hackney back in the year 2000, right? And social work has sort of disappeared as a profession. What happens now is that we manage packages of care.
Yeah.
So someone comes in, does an assessment, thinks that you might be lonely, thinks there might be some carer support, and then they put in a package and then it gets monitored. We don't look at the whole person. If you think about when we were younger, we used to have a family GP who knew us by name.
Yeah.
We knew them by name. They knew the whole family history. Do you know what I mean? And that disappeared. The technology has the potential for us to repersonalize ourselves again. And because we went to the most naked, cold, just going to the bone, right, of what it means to provide care, we have to reverse that decision. This is what I mean by I want an overarching thread. Because if you think about it, social care is an obvious miss. But it's because people can't see the technology can bridge that gap. If you think about it, will data flow and follow the person, not even the patient? And if that was done, we could follow them into community settings, into social care, all the way back into rehab, prehab, the whole thing, right? But we're not doing that. And I think the vision isn't there. These are just a series of things that we're overwhelmed with having to deliver. And the thread, I think, is what the country needs.
And I think we need to be absolutely joined up in everything that we're doing. So I'll give you an example. So I contacted my IBD team yesterday and I got a message back on my chart, Epic, from the team because they couldn't get in touch with me.
That wasn't the message, by the way. Epic.
No, it wasn't. No, that wasn't.
I don't know what it means.
But no. But the solution. Sorry, apologies.
For our audience, for our chronic disease, we got an information back from an EPR,
from an EPR, and an electronic patient record. So I got a message back. But for me to answer that message, I have to pick up a phone and leave a message on a answer machine. So obviously there we see we've got this high, rich, this EPR that's rich in functionality and features and functions that enables a clinician to communicate to me, yet I have to go back to sort of this.
All right, again, I'm going to jump in because it's so complex. And if you bear with me, there's 3 strands to what I want to say. If we were back in the 1960s and saying we want to get to the moon, the aim is, JFK stood up and he went, we're going to put people on the moon. How we do that was then worked out by people. And I think what this is, it's not a moonshot. It is a very comprehensive, we want to improve. For the first time in 77 years, we're going to look at the NHS and we're calling it the NHS. I would suggest there are practicalities in the aim, the plan, let's call it an aim, that will address social care issues. The NHS app is a front door. I think there are, if you look at the statements of I as a patient will be able to throughout the document, then actually it does address some of the things. And so that's one thing. It's very difficult to say, I want to go to the moon and I'm going to do all these things. And again, last night people were going, this is scandalous, we've got all these aims. So we can't do it piecemeal. You need a big aim. You need a moonshot, right? The other thing I'd say is this. I was super privileged. One of my roles was a voluntary role that I'm peer voted for, which is chair of the Health and Social Care Council of Tech UK. And we met Wes Streeton and Peter Kyle about 4 months before the general election in a somewhat private room. Private audience, there was about 7 of us, along with their special advisors. And to that point, they want to engage with industry. And I was going to that evening and I thought, you know what, I am pretty tired of politicians not delivering for us. I don't care. I am apolitical. I don't care what party you are. I want the best leadership and I want the best outcomes for the country. That's how I entered the room. And at that point, Wes Streeton was a lot of rhetoric on TV and blah, 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 which I was a bit sick of. When we got into the room and they introduced themselves, it was a really different environment. And what Wes said was, he started with the social determinants of health and said, if we don't fix that, we're never going to get to the front door of the emergency department and the people who are inappropriately in the hospital. We're never going to change society and the burden on society and the burden on people's lives. And I honestly, and I said to him, do you know what, I'm really impressed. You've really switched me on to this. However, I am going to hold you to account. And he said, I hope you do. And I'm following this up. 2 weeks ago, we had the NHS Confed. And Lord Victor Adebowale interviewed Wes during that. And Wes gave the same impassioned statement. Now, I don't think people have seen the before and after. And I'd like to say this. I think Wes has kept his word. I think he went to Treasury and government has kept their word to a point. They've come up with £10 billion. And importantly, they said, we're ring fencing it. Because we know what money does. It comes along and it gets snaffled to pay to fix the front door of the ED department because we've got people. So I think that's not explicit. And you wouldn't expect people to read that in the plan. So that hasn't been stated. I believe I've been very privileged to have a certain number of insights to say, I don't think you would actually, when I started this work and accepted it, involvement in the plan, I said, we will never, ever please everybody. So let's do the best that we can. And all I would say on balance is that maybe it's 70 to 80% of the way there. And what we've got the chance to do is go and hold people more to account, ask for more, iterate. And I would urge people to read the plan as best they can, go with an open heart as well as an open mind, and with forgetting about what was wrong in the past, learn from that, bring it forward and say, okay, how can we apply this best? And really importantly, how can we share that knowledge with as many people as possible so that we're not reinventing, we're not competing, we're just moving forward. And I think that's what I'd appeal in every aspect of whatever the plan is. And challenge, criticize constructively, but let's try and take it for what it could be, not for necessarily the negativity we might read it as.
No, absolutely. And looking at the positive, Shane, as well, and sort of like, bring Clive back in from that sort of social care perspective as well. So neighbourhood health services and looking at that. When I was reading through the executive summary and sort of like, looking at that, I think it's a great idea. Multidisciplinary sort of like, neighbourhood hubs and all these initiatives. How do we, how do we achieve that? How do we make that work?
My immediate question is, why didn't polyclinics work? Why were they scrapped in 2011? Yeah. Okay. Do we know what's the corporate memory?
Do you have an opinion?
Do I have an opinion?
Yeah, so why?
Yeah, they didn't have enough of the right people to staff them. It's a bit like Nightingale hospitals.
Can I add into that independent sector treatment centres?
Yeah, sure. All the low complexity stuff being farmed out to ISTCs, and the NHS kept all the high complexity stuff and didn't necessarily make sufficient money out of that. Anyway. Yeah, but the issue is corporate memory, I think. So we've come to this, we've got a whole load of ideas in there, and it does worry me sometimes that, as Hassan said right at the beginning, a lot of this is not new, okay? Stuff has been tried before. I was in the NHS in the 90s with GP fund holders, right? Which they were holding the funds for a local neighbourhood, basically.
Yeah.
Right? So that was 30 years ago. But, I mean, we've done these things. The question that I have is, why didn't it work? So if you go back to and this was something Roy Lilly said today, I think, if you go back to the Darcy clinics, they were done in a period of relative wealth.
Yeah.
Okay? 2008, 2011, relative prosperity in the country. Okay, the NHS had been getting a chunk of money. Yes, we went into financial meltdown. There was still money around. The question is, why didn't it work? The follow-up question is, okay, what do we need to do differently now to get it to work in these financial circumstances, which are actually quite different to those, if anything worse, okay? So how do we make it work now? Is it about getting the right staff in? Do we recruit those? Are they going to be taken out of hospitals? Because actually you've got to parallel run these two systems. It's like the mental health thing that they tried 2 years ago, okay? They said, we're going to shut down the inpatient wards, we're going to move people into the community. So they shut down a load of the inpatient wards. They didn't set up the community resource to handle those people, okay? And so therefore the whole system went into meltdown. It's still in meltdown, particularly for child and adolescent. So the risk is that you don't run them in parallel, that you try and take people away from one. Now, if they do run in parallel, the obvious question is, have they got the funding to do that? And have they got the people to do that? And where they're going to get those people from? I think it's a great idea. I love the idea of neighbourhood care. The Australians do it incredibly well with cancer. They have these one-stop shops where you go in, you get diagnosed and treated and everything potentially within 24 hours in the same place. Brilliant, okay? I love it. Can we get to that? Yeah, I really hope we can get to that. But I need to be convinced that the plan to do that makes sense. And that delivery bit at the moment is missing. So I'm reserving judgment on it. I think it's a fantastic aspiration. I want to know how it's going to be done.
So so it didn't work before, okay, and we've gone around that sort of route before. Have we learned our lessons from that? Is that reflected in the plan or in the aims within the plan?
Are there any lessons learned, discussed in the plan?
This touches two parts of my career. One in about 2002 when I was on, it was a normal GP clinic where we co-located social workers and GPs together to try to make something that would work co-located in Hackney. And that's the beginning of Murder Mile, if you're familiar with that area. More knife and gun crime in Soweto in that little bit there. The other part of it was 2008, Healthcare for London did the polyclinic evaluation, and I was at Waltham Forest PCT. So I've seen at different stages of my career the number of things that would take place, and no one ever learned the lesson and wrote the lesson and took them further. So Clive's dead right that there's an organizational memory gap from doing so. But let me take you a bit deeper into why I made the comment earlier, which is also relevant here. And the example I want to give you is of skyscrapers in New York. Skyscrapers in New York were a solution to a particular problem, which is that they needed to do more with the land that they have, but they had bedrock. So the skyscraper made sense. And it worked because they all aligned on the fact that it worked. You go to a country, I don't know, let's just say you go to Dubai in the UAE, and there's desert, and then they have a skyscraper. The reason they have a skyscraper is because that is now, in their mind, a symbol, it's totemic. It's an example of what they want to be, but it isn't why they need it. And sometimes I think we have bits of things that come from other countries where we say we need that thing, but it's not plumbed in, and the purpose isn't driven. So you could very easily have something that was a one-stop shop, but no incentives are there. You haven't thought about how the handoffs work. You haven't thought about who loses, who actually has to do more work as a result, and the whole thing falls apart because someone has just thought this bit of innovation is important. That's why most futurists are useless, because all they do is think of the symbol of futurism and not the practical bit. And they leave it to the rest of us to decide and work it out, and it hurts, right? Truthfully, that's why I make the point about these being many good things, but no overarching plan. People will buy into the plan, not the bits. And to use Shane's analogy and stretch it too far, if I told you that you were making an engine, and I didn't tell you why you were making the engine, it wouldn't be the same as if I told you we're going to get to the moon. That's the difficulty with a lot of these things here. The overarching thread doesn't help us plug it in. That's my concern.
If I may, I think, and I really welcome everything that you've said there, Hassan. Incredibly powerful. Very quick anecdote. When NHSX was set up, CEO Matthew Gould came along, he was appointed, and a month before he took appointment, he took a knapsack and he went around the country with no aides, nobody. He just went and spoke to people, I would call it the front line. And at the end of that month, he was, I don't know if he was offered or he asked for it, he said, can you get some people together and give me what he called the long view? And he got some of us that have been around for 3 centuries, around a table from different aspects. And I was representing industry. There was people from primary care, from acutes, from all over the place. And there was about 7 or 8 of us, and we went up to Newcastle. It was a wonderful Professor Joe McDonald who hosted it. And he hosted it in the building that was used to create Stephenson's rocket. And again, if you indulge me, chaps, for a minute, an audience. The night before we went for dinner, and I'm walking along Newcastle, and there's this beautiful bridge. And it is there, and it was built out of steel over 100 years ago. And I kept thinking, my goodness, the people who created those rivets, would they think it's going to be here in 100 years' time? And I remember then going into this day and we talked about the long view. And I remember thinking this, the changes that we make, the decisions we make now, the architecture, if we're lucky, you might see in 100 years' time. And I truly believe that's the opportunity that we've got today. Now, I'm genuinely humbled and excited. And in fact, I even got emotional as I read the plan yesterday to see what was in it. And I just want to talk about a couple of things. The population growth since 2000 and 2010 has been extraordinary. You know, we've gone from 63 million people to 70 million people. It's a 10% increase. Our infrastructure didn't work then. We didn't have big enough hospitals. We were taking them down in the 90s under the government there. So somewhat there's a necessity. I'm very privileged to live in the Frimley Park area in Berkshire, in Windsor. We have brilliant healthcare services. We're very privileged. But my GP can't cope. So they don't have out-of-hours services. They have in-hours services. So you go to the GP, you can't get in. They say, don't worry, we've got an in-hours service, which happens to be on the site of the very old hospital, which should have been knocked down and made into a hotel by now. And you can go there because we've got this contract. Because the last thing you want to do is actually go to the acute. Because this year I've been through all of the services, tried to use the NHS app, 111, you name it. I understand the thing just doesn't work. So if we start with an aim and work backwards from that, but I think, as Roy Lilly would say, and Dr. Terry Porritt, start with a patient and work backwards. So I think locally we know what we want. The thing I'm going to come back to again is knowledge share. And I'll just finish on these 2 points. Knowledge sharing is something I'm desperately passionate about, because for everything that I've learned through my life has been because somebody has donated time and knowledge. Whether it was hundreds of years ago when they wrote it down, or whether there's clinicians that I've been able to sit with after surgery to explain to me why, when I was a buyer in hospitals, why I needed to buy certain types of equipment. And they showed me physically those sorts of things. The knowledge sharing we cannot underestimate, and yet bizarrely it's free mainly. People will willingly give, as we are today. And Hassan, you're sharing, Clive, you're sharing, Dean, you're sharing all of your experiences freely for everybody to take advantage of that. So I'm going to put a shameless plug in. The Academy of Fabulous NHS Stuff was set up by friends to do that very thing. But the license you're being given today is different. And I don't know that people are privileged enough to hear him. I've been a fan of Sir Jim Mackey long before he was a Sir. I saw him as a CEO and as somebody who was CEO of something called NHS Improvement in the day, where he made his aim that CEOs and leaders across the health sector would be able to give them time and space to fix the problems, because they're too busy and have been trying to fix the hour that is, the problems that are here right now, and be able to step back and do some strategy. Now, Sir Jim, again, up at NHS Confed, this is the most recent. So he's been in office for a couple of months as CEO of this country, but with a lifetime of experience running acute, community, primary care, social care services. He did all of that in his locality, and he made it his aim. I call him one of the best social entrepreneurs. He additionally created 5 businesses that's owned by the NHS. One of them's £1 billion organisation, an incredible entrepreneur. And he said, with Lord Victor Adebowale at NHS Confed, basically we have an opportunity. Let's do the right thing. And not go and change the rules, but do what you think is right. And I think that gives you license locally to do the right thing for you. And I hope what we're seeing here, with the best will in the world, is a cultural change. And if leadership can, and if you look at Glenn Burley, who's on the board, if you look at Claire Fuller and the stock date she did for GP, you look at these people, and honestly, my opinion is they are real, they have been at the front line, they have made things happen, they have got the scars of that, but they are saying, any of us have all of the answers. Try and do the best with what you've got. And if that culture permeates down through the system, but it's going to take time. It's going to take longer than their service time.
It is going to take time, and that's really interesting you saying that, Shane, because that whole knowledge thing, and you say about, and I'm a big believer in knowledge transfer, and you're absolutely right. Everyone around the table here
pinch with pride before.
Give their sort of time and their services sometimes sort of for free. And I use that sort of example every time we train, and I am going to bring in, because I have to bring in clinical risk management into the sort of like fold as well, because we've had and I'm just using it as an example of that culture, is that NHS England brought in these standards, mandated these standards, and then sort of stepped away, and it's almost get on with it sort of attitude. So I'm trying to sort of change that story, and trying to sort of, whenever we train, is to say to people, you are the ambassadors, you are the people now that need to move that forward, you are the people that need to raise awareness and move that on, because nobody else is going to do that for you, and we need to get it out there to the masses. And it'll be interesting, sort of like, Clive, of all the initiatives that have sort of, come in the recent sort of like year or so with PSERF, like sort of patient safety initiatives, etc. And I know we spoke about this on our first sort of outing of the Only Ways ethics around, there's those sort of bullet points around sort of like, patient safety, sort of like learning will be sort of like, there for everybody, and sort of like must be sort of like pushed, etc. Whereas, I still bang the drum around, well, digital clinical safety, as we call it, but I'm trying to change.
Two sides of the same coin.
Yeah, and I'm trying to change that landscape, that it's digital patient safety. They are the same sort of like, it is patient safety. It's all about preventing harm to the patient. So why aren't we seeing that sort of like pushed in the same
Was the
sort of
phrase
like
patient
view?
safety in the plan?
No.
I mean, the culture at the moment in the NHS, and this is a fairly provocative word, but I'll say it, is toxic. Okay, it is toxic, and we see that through things like on the hub, patient safety's learning and engagement platform, pslhub.org, available on all the browsers. So if you go on there, you can, once you're a member, and it's free to become a member, you can share content yourself, okay? And we have had a number of people who say that they're not willing to do that because they don't want to do that identifiably. We get lots of NHS people who are members, 50% of our members are NHS. A lot of them use their private emails because they don't want to be identifiable, even though their email is not shown. And so we've had to make an anonymisation feature so that people can share content anonymously because they're too worried for their organisation to see who they are. Okay, so that culture, I do believe that the people at the top of NHS England are positive and set a good role model, but this unfair, unjust culture has been in the NHS for far too long, and people are scared. You know, they're scared to speak up. You know, the freedom to speak up guardian position being axed is it's quite ironic, really. So, you know, I worry about that it's not going to change. And without that change in culture, lots and lots of this stuff that is in the plan won't succeed because it needs people to be open and receptive to that. But they also need to understand the burden. So, give you an example, the NHS Health Store. Okay, so Orca, who I've worked with for many years, helped to run the App Store, the NHS App Store, several years ago for NHSX initially. Why did that inevitably come to an end? X felt that they were standards and policy people, not delivery people. But the other reason was because over half of the apps that were already in the App Store at that point, the App Library, had changed versions significantly and needed re-reviewing. Okay, this is not a one-off thing. If you're going to have endorsed apps in a health store, which sounds like you're going to have to buy them, but library, then you've got to undertake a commitment that you will continuously review them because you are assuring quality regardless of how many versions they go through. That's the sort of thing, again, that Hassan was talking about in terms of you've got to understand the handoff, the levers, the commitment. That's a big commitment, having a health store. It's not just a one-off, oh yeah, it's fine, let's put it in, or it's got a DTAC review, that's fine, let's put it in. You know, that version of it may do, but if it totally changes 6, 12, 18 months down the road, are you going to re-review it and re-accredit it or whatever this is? Because that's a commitment, okay?
May I just say, I love the example, and it is spot on. It's another thing that sounds great, is actually correct, but done almost because we think we need it without the requisite steps beforehand and bringing people on a journey towards it. Each of the individual elements of the plan are fine, right? I'm looking for a thread because I want to gather people behind it. I want citizens behind it. I want staff behind it. And you're dead right that there's such a feeling of morale not being where it needs to be, that we're losing people. They're quietly quitting. Lots of people in the job market right now. Healthcare, or health and care, is in need of a bigger mission. And that's really, if I had to give a negative about the 10-year plan, it's that it hasn't really given us a shot in the arm. It's given us all the things that we probably would have to do, but it hasn't done it in a way that's really made us feel joyful about it. And therefore, the contribution of so many good people towards it and the energy being used on it right now still doesn't leave us.
Do you think there's too much to give a shot in the arm? Do you think it's diluted focus?
I wouldn't have minded many, many things if there was a very clear focus. And the focus they've put has been the shifts. But those shifts are not inspirational shifts. In the way that in the way that getting to the moon was an inspirational shift, right? That's what I'm talking about. You need something that says, we are now going to move to a learning health system, or we're now going to embed pathways across health and care, which means...
Well, pathways will be fundamentally embedding digital technologies. They won't be bolt-ons.
But may I just say then, to Shane's earlier point, that isn't actually a goal in and of itself. Being AI enabled isn't the goal.
No.
And that's why I'm suggesting that Wes Streeting and his team actually know the goal. They're smart enough to know the goal. They just haven't put it here.
Yeah, I think, again, a couple of things. You know, we all know this is going to transcend not only governments, but the individuals who are leading the top right now with best one in the world. Yeah. You know, so Jim's team, Wes, Keir Starmer, even the Labour Party. It's going to transcend that. And to be fair, I think they said that at the start. So we're going to go with some 10-year aims. This was before they were in government. And that means financial planning, it needs all of those things. I'll reserve my own sort of opinion. I hope that actually what the aim of the plan is genuinely, we had this discussion after we'd produced our materials, and it said, we got some feedback to say it wasn't sexy enough. Now, this was in digital data and technology, right? And so people wanted to make it a little bit more, and that was the phrase that was used, wanted to be more sexy. And I remember saying to the group, well, I've got to be honest with you, when I was going to school, I never thought I'm going to grow up and work in a sexy industry, which is digital data and technology. I didn't know actually where I was going to end up. But in all seriousness, the business that we're talking about is serious. It isn't about being sexy. I'm not going to challenge anything you've said, Hassan, because I respect you immensely. And also, it's a measure of how it's received. So I've seen it from the inside. I've said that, already that I'm kind of humbled by what it's going to try to achieve. I think it is, and we said, hang a minute, a plan has deliveries with it. We've not discussed delivery. Now, it has to be owned and taken on board. And I think that's the work that needs to happen. I saw the launch with Keir Starmer. Unfortunately, I don't think it wasn't the empowering, wonderful launch, because things happened the day before. We were actually distracted by the wonderful human being being visibly upset in her day job in front of an entire world. So I think it's a shame. I do hope that actually people like Sir Jim, who's going to be responsible for delivering this, of getting the start of it. If I may, I want to just draw on several points. Patient involvement for us was the number one thing when we sat down. It wasn't about what do we do with digital and data and technology. It was how do we make life better for our citizens, our loved ones, our people, and it's patient involvement. To me, clinical safety, as Dean, you and I have discussed for many years, I've had the great privilege to work with you for nearly 2 decades now. We put clinical safety at the heart of everything that we do. We don't actually say patient safety in that phrase, but it is implied. And I think that's what you've got to do with the plan. You've got to imply, does this mean social care? Does this mean mental health? Some of it will be explicit, some of it won't. Now, I'm very privileged to be CEO of 2 organizations, and my own organization, Temple Black, has 2 divisions. We have the healthtech consulting arm, where we advise companies on what they can do with their technologies. And one of my specialisms is writing business strategies in healthtech. And the other one is quantum health technologies, which is whereby we run and we have run large patient real-time databases. And the quantum part is I want to see us take advantage of new technologies, the quantum capabilities that are coming on over the next few years, because the amount of data we want to process real-time should not be limited. And our current technologies I think, will become quite limited quite soon and very expensive. So drilling down from that, the clinical safety, we should not start anything unless clinical and patient safety is at the start. It's not fair to invite people to work in an environment that isn't safe. That means joined up data. And I just wanted to mention a bit about the GP and the app and the change in healthcare. On my not-for-profit, where I'm CEO and I work with a wonderful GP, we have discussed the change. We provide risk scores, which is about you taking advantage and knowing what you're at risk of with cancer or cardiovascular diseases or other things. But the wealth of knowledge that a GP who was trained, and my friend was trained over 40 years ago, what they were trained with and what they have to deal with now is so complex that actually the GP and what I think the app should be is a guide throughout your life of somewhere to go. And the plan does talk about it being that advocate. Care navigation. And I think we've got to, we cannot go back to, we will never have a family GP unless you pay privately who knows us. So you're going to have to change the system and help you, guide you, get the knowledge, the best and latest knowledge in the world for your needs.
Absolutely. And leads us quite nicely on to sort of genomics actually and wearables, because that's, that's all about the data. But prior to us sort of talking about that, I'm going to change tack slightly. I don't know whether you saw the sort of stuff around the innovators' passports and some stuff that's come out. Absolutely scared the bejeebers out of me, and I made some sort of like comments in relation to that. And I know that sort of a colleague, Alex Graham from Arbed Graham, sort of put some stuff out there, and was almost sort of pleading or putting it out to the audience to say, is this going to go down the digital health technologies route? Because it implied, and the two examples that were in there were around dressing, surgical dressings, etc., and stuff like that. So it was talking about sort of physical medical devices rather than technology. And I was like, blimey, if it does go down that. But I think where it scares me is that if that is the sort of like the path that that's taking, and these are the decisions for sort of, you know, cutting the red tape, as it were, are we going to see this with sort of digital technologies where it's like, I'll give that to one health organisation, they can assess it. If they give it the thumbs up, just whack it out into all the rest. Because that's really dangerous, as we all know, round the table, because we're really sort of like, you know, going to be on a sort of, you know, dodgy ground, especially if we are promoting wearables and sort of all of these technologies that are going to sort of, you know, be the enablers for us getting that data. But as we know, if those platforms don't do what they're supposed to do, then we're at a loss.
So I'm really positive about this. I like the idea. There's been too much noise for buyers of tech solutions, health, medtech, biotech, and there's been too much noise, maybe disconnection for vendors trying to reach the buyers. Okay? So the whole system is disconnected, and I think this is a really valid approach to trying to bring connection between them. I don't know how it's going to be done, but in principle, I really like it. It's a great idea, and it should be medtech, biotech, and healthtech. However, the questions are around safeguards. Okay, now I don't think that an NHS trust should be the arbiter of whether something is safe, useful, efficacious for the whole of the NHS in all different care settings that it could be used in. I don't think so. Okay. I think it needs somebody else to be doing that with them, with the first trust or the first ICB or PCN or whatever it is, neighbourhood care centre, as their partner. Who is that? Don't know. NHS Innovation Service, something like that. Okay, maybe it is. They have to be resourced and they have to be expert to be able to do that. So I'd like to see that sort of thing happening. If there's some detail under that, I'd like to see that detail. In principle, while there are safety issues, I think that this could be a really positive step forward.
No, absolutely, and I agree. But it has to be done right.
Would you mind me saying that?
Yeah, no, you crack on.
I'm definitely in the same boat as Clive, saying that this is a good thing. But I have a particular reason for saying it. I'm on record as saying that the noise for the buyer, while bad, isn't as big an issue as the variability, what you might call the unwarranted variation, for the innovator making a different sale each time. So imagine that you get to 7 or 8 or 9 sales. You've had to sell to a different person in a different way. You had to use different language, different forms, and you can't get to scale, because the whole point of scale is that you're hitting the same type of user with the same kind of sale over and over and over.
And there's ongoing support in different ways.
And so if the passport was presented as a way to reduce the friction and the variability, then I would understand why. This is kind of why I keep hitting the same point here. I can see multiple things here that are valuable in their own right, but because we haven't been given the actual reasoning behind it, we've been given the totem of a passport, we're now stuck having to speculate. Whereas if it had been given to us with the overarching theme of, we want to make it easier for us to reduce that variation, therefore we choose a passport, we would all come in and say, great, this is what the passport needs to be or not be. And I think that's where great ideas are all mixed in. It needs somebody, and by the way, have you noticed I've not said anything about delivery? I know the delivery plan will come out later. I've got no problems with delivery. And Jim Mackey is like the guarantee of delivery. I don't have a problem with delivery. My problem is about the narrative not being inspiring enough or connected enough.
Yeah.
And I think that comes down to so many people giving good ideas,
Yeah.
but it's the cognitive load of the team to try and put it together. And the 10-year plan is, and I congratulate the team that wrote this, and don't have a go at them, because how would you put together all of this? What input must you have received to synthesize this?
Yeah.
I'm not saying that they've done a bad job. I'm just saying that there's a level needed. That level is where all of our focus should be, rather than criticizing the people in the plan.
Totally.
And I think it is to do with, don't give me a thing that has worked in Australia, for example, the one-stop shop for cancer, without thinking about why we need it and how to really implant it and embed it here, because the handoffs will kill us. And then 4 years later, we'll wonder why it didn't work. And someone will reinvent the wheel for another planet.
And you're right. And just coming back to that innovator's passport, I think it is a great idea. And I don't want to sort of like, but obviously, living and breathing that whole regulatory compliance space and seeing the sort of like, it's what I do. And, look, DTAC, revised version coming out in August. NHSE will kill me for that, but hey, it is.
Can I ask you a question? What if they put in the plan, we want to embed digital clinical safety and digital patient safety with a passport? It would have changed your perspective.
No, absolutely it would have. It's just that sort of like, look, and we know there's good and bad, but we have to make sure that, don't we, the underlying message and the underlying framework is absolutely on the money, because if we don't do that and we're not cognizant of every subsequent health organisation, look, we know in the real world they have different ways of working. We can't all work in exactly the same way.
No, but
unfortunately.
There could have been a blanket phrase at the beginning, in the intro, that all of these solutions, all of these ideas, will all be tested with the user. Whether they're patients, staff, citizens, whoever that happens to be, they will all embody the best user-centered design that is possible to bring to the solution.
Yeah.
They will be tested so that
assured,
so they'll be clinically safe and safe in use for patients. Okay. Now, it could have said something like that at the beginning. They didn't need to then say it for every single idea that's in there, because they're then stating their case.
And it's assumed then, isn't it? And then you can sort of move forward.
Right, I'm gonna put the flag up a little bit, right? A couple of anecdotes. Here we are, Friday afternoon, a patient safety learning office in a hot London, and we've got the window open, so you might have heard all kinds of London noises, ambulances and police and scooters going past. I feel that it's almost like we have the joke about you Wakefield bus and 3 double-deckers come at once. I think the entire estate of double-decker buses has almost arrived in the last week, because we've had NICE saying that they're going to help with approving apps. We've got the passporting, and then we've got the plan, we've got all this other stuff. And inside the plan, I have to say, it's things like capital has always been a problem, budgeting, we're going to move to revenues. So I'm going to say this to you, very, very quick anecdote. About 4 years ago, we started working with NHS commercial teams because a bunch of stuff didn't work. And one of the things we came up with was this concept, passporting. And here we are today, and it's interesting how healthtech hasn't adopted it yet. The people did, by the way, in commercial, they couldn't get it through Cabinet Office, and it's medtech who's come out first. So we'll go with that. And I think medtech and healthtech is increasingly over the future years is just going to blend. It is very difficult to see the two now. I straddle both sides of it. And I would say that actually our opportunity is to iterate. Whatever it is that we do, take what you've got. I honestly think, and maybe I'm just see the world coming from a dark place, and my time in my real roles and responsibilities as chief executives of mission critical companies, we saw disasters, and I always said, and Dean, you remember this, if we get it wrong in our work, people will die. If you get it right, you extend people's lives. You'll never know about it, and you'll never get thanked for it. And I think that's a great privilege. We, as technology suppliers and what have you, are custodians of people's well-being. That's all we are. But we take that responsibility incredibly seriously. But we have to iterate. Whatever it is that we buy, whatever it is that we supply, the one thing I really want to see demand of, and there is a bit under procurement in the plan, I am going to put my hand up and say I managed to get some of that in, which is you must be able to plug and play. You cannot lock yourself into a vendor, because here's the thing, you mentioned before about the you're creating an app and having it validated. AI, you've got to validate within minutes of it making a decision. And that's so difficult to do. We've got so much coming up we haven't even conceived of yet. No. So I think, personally, I will urge people to put their energies into iterate. Take what we've got. And again, there was a culture in our work on the plan, which was you've got to start from where you are. It's not ideal. We've got horrible infrastructure in places. We've got people who have hidden the fact that they have got stuff on servers that isn't safe and secure. Why? Because it's too challenging almost for some of them to admit. That's not a good culture to have. So we have to start with where we are, to do as much as we can. If something works, the emphasis was on let's not have more pilots. Let's have a phase 1. If that phase means it works, great. It doesn't. The passporting bit is about taking the credibilities forward, and the burden particularly on companies, which is whatever framework, and again, it was all part of the same work, to supply. We urged the NHS to use frameworks as opposed to individual procurements every time. We got that, but then we had 53 other things. And then we thought, well, 53 is too many, we got it down to 35. And then the legal challenges started from some of those framework providers. The status now is actually, it isn't a bad thing to have specialist frameworks. If you provide audiology services, if you provide ophthalmology services, specialize on that. There are some generalist things too. I think what I am encouraged by is there is iteration. There is learning from the past. And I think we, as an audience, as gentlemen around the table, but as our audience, we have a responsibility to speak up.
Yeah.
And I would encourage people to never give up on what they believe in. If they believe a thing was wrong and they don't believe it's heard, because that's the one thing I get throughout society and in our work is no one's listening. No one listened, I gave up. Please don't give up. It's heartbreaking, but please don't give up. And just keep that moving forward.
He's so positive, isn't he? I mean, he's making me...
it is. Come on, absolutely so positive. And do you know what? It leads us really nicely on. And this is a big thing of mine, because I think we're near time to sort of like wrap up. But our last sort of discussion around which was sort of like topic number 7, which we'll move on to, the whole feedback loops, transparency. Patients, can they help redesign of service? And I come at it from, again, my clinical risk management experience.
In real time,
and in real time. No, absolutely in real time.
Real time. Now matters.
No, absolutely
Not
now
decades.
matters. And I'm an absolute big believer in that, because it's exactly the same in what we do in relation to, as soon as you switch a system on, and Shane, you'll know this as well, we've had lots of experience of EPR deployments in our time, many to
thousands of
sort
people
of like talk about. And that's the bit that matters, feedback at that time. Do you have the right processes and procedures in place for people to feed back into the design in relation to that and the processes? Because it's the only way
real-time feedback
that we're going to be able to improve.
Allow me to be controversial for a second.
Go on.
I think that is important, but not the first step. For me, the first step is thinking what the service should have been in the first place. So far too often we see around the world, not just in this country, people saying we built the service, but people aren't coming. We can't reach the community. It's because they weren't there from the very beginning.
Yeah.
And the analogy that I've given often is of a pop-up restaurant or a van. It does really well, then gets turned into the restaurant because people enjoyed it, people used it, and then they went, right? And I think if you had that kind of engagement, that gives you the chance to get the real-time feedback from the very beginning, because you have a social contract with those people.
Yeah.
And I think we don't design services in the co-production way of doing things naturally. It's not the way we've done it before, it's not the way we train medical students, it's not the way we design things. I would love for it to be embedded. And actually, to be honest, technically, it's not that difficult to do the things that we need to do. Often technologists and companies are saying, I can see the way to do it, just let me in.
Yeah.
Right? They're getting blocked from culture and the way we do things. That's why I think deep down, the wrong people have been running healthcare for too long. We need to be thinking more about how we bring in disparate voices and therefore early with industry. And this has been stunning for me, how poor the engagement has been from the NHS as a whole with industry who are trying to help. And often you get people saying, I don't want to work with industry, not realizing that there was tons of expertise, money, goodwill. This isn't just about the pharmaceutical industry. Think about Tech UK. Think about all of the major suppliers there who are saying, no, we want to make sure this works. We all live it together.
I donate about 10 to 20% of my time per week on what I call pro bono activities. I think that is a responsibility that I have, not to give back, to give forward. And the reason I'm involved in Tech UK, which is, I'm involved in so many different aspects and have been over the years, and now encouraging other people to take them on, from procurement, from integration, interoperability. But it's all been about also the listening, the learning. And my advocacy right now as chair of that group, and a two-year term, I'm not saying I'm going to fulfill that. My work might be done. But it is to make sure that we're bringing big and small and enabling a culture and environment where things can be invented. When I started working on that, we saw so many companies say, well, literally they would say in private forum, well, when the NHS knows what it wants, it's got the money, then we'll listen. And I said, that's just not fair, guys. You've got to come to the party. Oh, well, we'll wait till the new Secretary of State's in office. Oh, I'll tell you what we'll do. We'll write some advice to the new Secretary of State. Why can't we iterate? And if you've got a piece of knowledge right now, I honestly believe you have an obligation to share. You don't have to take that obligation. But I think if you're in society today, why not offer what you have? So nobody's got a single answer. And again, I learned something as chief exec a really hard way. And I meant it with good faith. Having worked at the front line in a lot of roles before I eventually became a chief exec, people would come in and say, I've got a problem. And I'd say, you're the best person to know what the answer is, aren't you? So please don't come to me with your problems. Come to me with your problems and your answers. What about me?
No.
Oh, just generally.
By a boss.
Oh, yeah. And then I realised I was wrong, because I wasn't saying, come and tell me the answer, do the work. And actually, we changed it to say, please come with your problems, please come with your solutions, and we will work it out together. And that's when I stopped being a boss and realised that I was at the bottom of the organisation as chief executive. My job was to support the managers and the leaders and to support the front line. And I think that's what a boss's job is.
You're enlightened, sadly, there's a lot.
No, I think people like Sir Jim get that. And Ed Smith, who was his chair. I genuinely think they do. They realise that it's a privileged position, and they'll try and create that time and space to allow people to get the best. Dean, you'll know, I was never in the offices in IMS because I spent 80% of my time at the front line of where the customers were, because that's the only way I could learn what we needed and what we were doing. And I encouraged all of our teams to get out as well, didn't I?
I want to pick up something that Sam was talking about briefly. The co-design, co-production stuff. Even if companies want to do it, the problem is finding the patients, citizens, people to do it with sometimes, because there may be different cohorts they need to engage with. And apart from doing another pilot, how do they find these people to do it with? So one of the things that needs to be created, and I've talked about this before as part of the sort of tech group that includes the Patient Association, Parkinson's UK, Stroke UK, loads of us. We need groups of patients who are interested in looking at tech and helping SMEs and others to develop that further. Because without those individuals doing the co-design, doing the co-production, it doesn't work. And it's difficult to bash NHS about this because they are constantly firefighting.
Yeah, totally.
And, they're maxed out, they're dealing with patients. And so almost you need this sort of bimodal approach, okay? The sort of thing that IBM used to talk about in IT. You've got your business as usual, and then you've got your forward-looking stuff. It's sort of the Google X thing. You can have a day a week, just do that, do projects that you're interested in doing, fine, we'll ring fence your time. And it's really tough to do that sort of thing. But I do believe that actually there are lots of clinicians who would really like to have a few hours a week ring-fenced to work on the forward stuff. Yeah. Okay? How can I make the service a better place with tech, re-engineering processes, whatever? Let's get the SMEs to work with them. Let's have cohorts of patients, population groups that we can work with. Who's going to do that? Who's going to make that happen? It needs a central function to do it. It's not just going to happen individual trust by trust.
No.
It's got to be coordinated centrally.
And it's interesting, and I'm going to round up now with that thought, because there was an initiative that we were putting in place when I worked at Barkinghaven and Redbridge back in 2004, just before the interim came in. And I was part of that as Care Pathway Facilitator. And what was that initiative called? Fit for the Future. Back then.
It's a good
20 years ago. What a session. We've talked about a lot. It's been absolutely fantastic. I could sit here for hours, and we could do this. I'd just like to say a big thank you to all three of you for joining us on episode 25 of The Only Way is Ethics. I'm hoping with our audience that this is going to spark off lots of conversations, lots of interesting conversations. So again, a big thank you to Hassan, to Shane and to Clive. Thank you to everyone for joining us for episode 25. In episode 26, we're hoping to have someone that was supposed to join us on this panel. I won't tell you who it is, but I'll leave that to your thoughts, so you come back and join us. But thank you again, and have a good weekend.
Dean.
Thank you for hosting.
Thank you very much for the opportunity.
Thank you so much.